Hello everyone, my name is Manoj and today I'm doing presentation on atypical hemolytic uremic syndrome. So let's get started. Let's start with a brief background information about hemolytic uremic syndrome on the first slide. So hemolytic uremic syndrome is the clinical triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. As you can see on the right hand side, you can see three hallmarks of hemolytic uremic syndrome with all the signs and symptoms. And it is the hemolytic uremic syndrome is divided into two different subtypes. The one is typical hemolytic uremic syndrome that is associated with Shiga toxin producing E. coli and accounts for about 85 to 95% of cases in children. The second one is the uncontrolled complement activation of the alternate complement pathway due to the genetic mutation and is known as atypical HUS, and it accounts for about 5 to 10% of cases in children. All right, let's talk about the causes and effect of atypical hemolytic uremic syndrome. The first one is the bacteria Streptococcus pneumoniae that is also responsible for causing this disease. The second one, or the main one, is the genetic abnormality in the complement cascade. As you can see on the right hand side of this slide, I have included a figure of the steps involved in alternative pathway, where the C3 convertase is hydrolyzed into C3A and C3B. This reaction is monitored or regulated by different complement regulatory factors like complement factor H, complement factor I, and membrane cofactor protein. But when there is a genetic mutation of these proteins, this reaction is not regulated properly. So there is enormous amount of C3A and C3B produced, which ultimately leads to the intracellular damage of host cell. So other miscellaneous causes of atypical HUS includes um, several malignancies, radiation, pregnancy, infection from viruses and bacteria, and different types of drugs as well. So regarding the effect or the consequences of this disease, there are serious complications like kidney failure, high blood pressure, heart disease, and several nervous system disorder. All right, now let's talk about how we can diagnose this disease. So initially, we would do the complete blood count, glomerular filtration rate to establish three hallmarks of atypical hemolytic uremic syndrome, which are microangiopathic hemolytic anemia, thrombocytopenia, and kidney failure. Once we establish this, and once we see cystocytes on our blood film, we further go down for differential diagnosis to differentiate between atypical hemolytic uremic syndrome and other forms of thrombotic microangiopathy. For this, we can do the ADAM-TS13 activity. The greater than 10% value of ADAM-TS13 confirms it is atypical hemolytic uremic syndrome. If it's less than 10%, it is actually thrombotic thrombocytopenic purpura (TTP). Furthermore, we need to differentiate between typical and atypical types of HUS. For this, we can do the direct detection of Shiga toxin in feces and anti-lipopolysaccharide immunoglobulin M antibody measurement on patient sample. Similarly, we can do more genetic screening to confirm more genetic screening for the complement factor H, complement factor I proteins to confirm the clinical diagnosis of AHUS. All right, now let's talk about the treatment available for treating atypical hemolytic uremic syndrome. So the first one is the supportive care, which is a traditional kind of treatment. Supportive care plan includes dialysis, blood transfusion, intensive care of patient, and plasma exchange. Even though plasma exchange is presumed to remove abnormal complement-related factors like mutant proteins or anti-CHF antibodies, it is not able to treat the underlying disease. Plasma therapy has proven to work in some people, but not on everyone. but several past studies have shown the introduction of plasma therapy has decreased the mortality of patients with atypical hearts. The new treatment, which is eculizumab, is a monoclonal humanized antibody against C5. As we can see on the figure on the bottom of the table, so when the eculizumab is administered to the patient intravenously, it binds to the C5 of the complement cascade or the alternative pathway. It blocks the terminal complement activation by inhibiting the cleavage of C5 into C5a and C5b, and hence it avoids the production of inflammation by C5a as well as the formation of membrane attack complex by C5b. The next one, the ravulizumab, which is engineered from eculizumab, targets the same epitope as eculizumab, just with an extended half-life, which means it is exactly the same like ravulizumab, but when it is administered to a patient, that lasts longer. So when people have to go visit hospital once every 2 weeks, when administered with ravulizumab, they just have to go hospital once every 4 weeks. So this slide highlights the treatment recommendation for atypical HUS. It quickly summarizes the effectiveness of the eculizumab in the treatment of atypical HUS. Eculizumab has some greater efficacy than plasma therapy in treating and preventing atypical HUS. So in conclusion, I would just like to highlight some main points that I have discussed earlier. Atypical hemolytic uremic syndrome, which is caused by genetic mutation in the alternative pathway of complement system, is very rare but is associated with high morbidity and mortality. Now that we have very effective treatment for atypical hemolytic uremic syndrome, apart from supportive therapy, which is eculizumab administered intravenously to patients, even though eculizumab has been effective in treating people, there are still some challenges as it is very costly and need hospital visit every 2 weeks. So in regards to the prevention from the disease, this disease is caused due to genetic mutation mainly. So early diagnosis and treatment is the best prevention to stop from severe damage to our body from the disease. So this is the end of my presentation. Thank you for your time, guys.